we left off our discussion, or I'll overlap a little bit with kind of what we covered last time, so it's not exactly where we left off our discussion, with kind of talking about the cardiac conduction system. And remember, there's parts of the heart that are have their own ability to generate an action potential independent of nervous system stimulation, right? And so there's what we call the system of cells, cells that are connected that can make up this system as a cardiac conduction system. Remember, this is different than the cardiac cycle. Cardiac cycle is the physical or mechanical movement of blood through the heart, and we're talking about chambers and valves and so forth with the cardiac cycle. Here, cardiac conduction system, we're talking about the electrical impulse that propagates through the heart, all right? And what you want to do as a student is figure out how those two are related, all right? And so you guys will have time in the lab to take a look at that as well. But you really want to be able to start connecting what's happening mechanically, physically with what's happening electrically, right? And when we think about things, which one happens first when we have skeletal muscle contraction, right? Do we get a motor neuron firing before or after? So hopefully before, right? So the electrical stimulus precedes the actual physical event, right? So keep that in mind. Now, there's two nodes that actually have what we call spontaneous or intrinsic ability to generate action potentials. That's the sinoatrial node, SA node, and the atrioventricular node, or AV node. And here the SA nodes is going to be sitting kind of on the upper right-hand portion of the right atrium. And it spontaneously generates electrical signal, not unlike what we saw in the nervous system, and that propagates down towards the AV node, but also across to the left atrium. Okay? And then eventually it's going to get to a point, right, where it stimulates the AV node, and that's going to send a signal through this bundle called the bundle of His, and then it's going to the bundle separates into two bundle branches, one going down the internal portion of the what we call a septum. Septum means that it separates, and we call this the interventricular septum because it separates to two ventricles. It's in between the two ventricles, interventricular. And the word septum means separate. Okay? And so we get this electrical signal that's going to be going down. We get depolarization. And it's going to separate into these two bundle branches. One is going to be going down the left-hand side of that septum. The other is going down the right-hand side of the septum. Okay? So it goes down here. And then eventually reaches the tip of the heart, or what we call the apex of the heart. Right? And you're going to start getting the spread of that depolarization or throughout that cardiovascular muscle tissue, right? The cardiomyocytes. Okay, so the depolarization starts off with the SA node and spreads down in this direction. All right? And so here, this is the electrical stimulus that's going to cause the cardiac muscle to contract and what causes eventually the heart to beat. All right. And so here, the sinus rhythm, so if you just took out those cells from the SA node, they would spontaneously beat around 60 to 100 beats per minute. Now, how many people have a resting heart rate of 100 beats per minute? Hopefully not many, right? Okay? The nodal rhythm is about 40 to 50, so if you take out the SA node, then this is kind of a secondary pacemaker there. Okay? Now, we're going to talk about in just a second of why, when we're resting, we don't have like 100 beats per minute. Some terminology. If we get some other part of the cardiac tissue to spontaneously depolarize, right, we call that an ectopic focus. So basically we're generating some sort of spontaneous potential someplace other than the SA or AV node. right? So if we generate, spontaneous depolarization over here, right? Is that going to be very good for the heart? Is that going to make the pumping action of the heart efficient or less efficient? Probably less efficient, right? It could cause problems. One of the things is that, if you have an ectopic focus, that can lead to problems with getting adequate blood circulation and blood pressure issues, right? Okay. Right. So ectopic focus is just talking about having some spontaneous firing at a place other than the SA or AV node, right? It could manifest itself as the term you probably have heard of, fibrillation, right? So atrial or ventricular fibrillation, right? All right. How do people feel about general concepts of SA, AV node, electrical conduction, some basics? Is it making sense to folks? So nodding up and down. All right. Okay. All right. So like we said, most people with a resting heart rate isn't, like 100 beats per minute. Turns out we have innervation of the heart by both divisions of the autonomic nervous system, the sympathetic and the parasympathetic. We saw this before with a lot of other organs and tissues, right? They're duly innervated by the two divisions of the autonomic nervous system, sympathetic and parasympathetic. The heart is the same way. Now, remember the sympathetic, right? So is that the rest and digest, or is that the fight or flight? Fight or flight, right? So if you think about, right, sympathetic innervation of the heart, we activate the sympathetic nervous system. What is that doing to the heart rate? Going up, right? Parasympathetic, what do you think is happening to the heart rate? Going down, right? Okay? So remember that, because that's going to be really important. And one of the things is that the sympathetic, it innervates several places of the heart. One is that it's innervating at the AV and the SA node, and then also at some cardiomyocyte tissue, right? The myocardium. Now, since it's innervating at the SA and AV node, it can control the heart rate, like we said. But since it's also innervating the ventricular myocardium, the actual muscle tissue that contracts, it can actually influence the strength of contraction. So not only are you increasing heart rate, but you're increasing the contraction strength of the heart, which means that you're not only pumping more blood per beat of the heart, right? Because you increase the contraction strength, but you're increasing also the number of times that heart beats in, say, a minute, right? The heart rate. Everybody following me on that? It's really important. Okay? Now, if you remember, parasympathetic, major nerve, that is the cranial nerve that innervates a lot of the abdominal and here the thoracic organs and viscera, is the vagus nerve, cranial nerve number 10. And so here, branch of the vagus nerve innervates the SA and AV nodes. And it's parasympathetic. So here, parasympathetic, when that vagus nerve is going to fire, what's it going to do to the heart rate? It's going to lower it, right? So here, the parasympathetic primarily is affecting heart rate. It doesn't have the effect on contractility that the sympathetic nervous system does. Everybody following me on that? Okay? So it decreases heart rate. So it's not innervating the myocardium like the sympathetic nervous system. Now it turns out that the parasympathetic, the vagus nerve, there's some tonic firing from the vagus nerve. So there's parasympathetic is tonically firing, meaning that it is steadily firing to try to decrease heart rate. So it's kind of putting the brakes on that normal firing rate that we saw with the SA node. Remember, the SA node fires about 60 to 100 beats per minute, but here resting, we don't have 100 beats per minute. The reason is because the parasympathetic is tonically firing to decrease the heart rate, putting the brakes on that cardiac conduction system, right? So hopefully you can think about how could you raise heart rate without activating the sympathetic nervous system? How could you do that? How could the body do that? Remember, we're putting the brakes on the heart rate with the parasympathetic. How could you elevate the heart rate without activating the sympathetic nervous system? Decreasing the activation of parasympathetic. Exactly, right? So you could take the brakes that the parasympathetic is putting on. You could take those brakes off. And then what's that going to do to the heart rate? Goes up, right? So here you can elevate heart rate without even activating the sympathetic nervous system, just by inhibiting the parasympathetic. Everybody following me on that? Okay, so here you can actually elevate heart rate without necessarily activating the sympathetic nervous system, right? So we say that there's what we call vagal or parasympathetic tone on the heart, right? Because during normal resting situations, there's tonic firing from the vagus nerve to try to tamp down or decrease the heart rate. Everybody understand what I mean by tonic firing? So there's a steady rate of firing that comes from that vagus nerve to decrease heart rate. We saw something similar when we talked about controlling blood vessel diameter, when we talked about the autonomic nervous system, right? There's tonic firing from the sympathetic nervous system. We could increase that rate, decrease the diameter, decrease the rate, and increase the diameter of some blood vessels. All right. So hopefully you guys remember a little bit about action potentials when we talked about them with the nervous system. And if you remember with the nervous system, we had a resting membrane potential, right? And then when we moved that membrane potential to threshold, we fired an action potential, right? So we depolarized to get to that threshold. And once we reached that threshold voltage, we got an action potential. If we move that membrane potential further away from threshold, right, it is less likely to make an action potential, right? Okay? So it turns out that these pacemaker cells that are in the heart, in the SA and AV node, are a little bit different in that after they fire an action potential and you get repolarization, once it gets back towards what we say, we don't really call a resting membrane potential, there are certain channels that open. Sodium ion channels open, right? Where sodium ions more concentrated? Outside or inside of the cell? Where are they more abundant? Outside of the cell, right? So if you open sodium ion channels, what's that going to do to the membrane potential? It's going to depolarize or hyperpolarize? Depolarize, right? So we're going to start getting depolarization, and then eventually it depolarizes to a point where we reach threshold, we get an action potential. So technically, these pacemaker cells, they don't even have a resting membrane potential, right? Because as soon as they repolarize, they start depolarizing again. Okay? So technically, they don't have a resting membrane potential. Now, when scientists were looking at this, they were trying to figure out what's going on here. This looks really funny because they couldn't find a resting membrane potential. So they called this flow, this voltage, this current, they called it funny. And they called the channels that opened that cause it funny channels. So these are funny sodium ion channels. All right? And so here, these funny channels, when they open, they cause this membrane voltage to wander towards threshold, and then you get an action potential to fire. You get depolarization. Okay? That's what we're talking about in these pacemaker cells. Now, let me just finish this up, and I'll get your question, Tyler. Now, one of the other interesting things about this is a little bit different than what we talked about. Before, when we talked about the nervous system, this depolarization event that we saw was almost exclusively sodium ion. Now we actually put calcium ions in here, right? So here, there's calcium ion channels that open to cause, as part of this depolarization event, as part of the action potential for these pacemaker cells. So here, we've seen that calcium is going to be important for not only muscle contraction, calcium is also important for pacemaker activity. And then what other tissue did we talk about in 231 that calcium was really important for? Stores calcium. Bones, right? So here we're starting to connect how all these systems are together, right? Starting to connect them together. If we have a problem with calcium, we cause problems in all those systems. All right? Sorry, go ahead, Tyler. Mm-hmm. Well, you know, so you're talking about whether you're, so with, you would, a lot of meth, I think you have elevated heart rate, you know, and so yeah, you're going to get something a little bit different. We'll talk about some of those agents in just a second, right? But yeah, we're going to talk about some of those agents. We're not going to get into all of them, right? And so hold on just a second, okay? So to get to that, to the answer of that question, right? So here, for every action potential we get, that's stimulating the heart to contract. That's a heartbeat, right? Okay, so here, the rate at which we cause a heart contraction, a heartbeat, depends upon how quickly this membrane potential gets to threshold, right? Okay, so if we increase the slope of this membrane potential, so it reaches threshold more quickly, what's that going to do to the heart rate? So you can go up, right? Now, if we make this slope shallower, right, so that it takes longer to get to threshold, then that's going to slow down the heart rate, right? So let's think about some ways that this can happen, right? So how could we maybe make this slope steeper? What could we do? Yeah, so you could say open up more sodium channels, right? Okay, right? So that's another one of the ways you can do it. How could we make it, say, less steep, so shallower? So you could decrease sodium. What could we do with potassium? So you could increase potassium, right? Because potassium, if it's leaking out, is going to combat the depolarization event, right? And so here, when we talk about increasing heart rate, we call those chronotropic agents, positive chronotropic agents. Chronotropic agents are just agents that affect heart rate. Ones that elevate heart rate are going to be positive chronotropic agents. Right? So what do you guys think agents are called that decrease heart rate? Negative chronotropic agents. All right? So here we're getting to, talking about some of the critical ones that are chronotropic agents. Now, remember I told you that the sympathetic nervous system increases heart rate? What's a major hormone or neurotransmitter that gets released from those postganglionic neurons in the sympathetic nervous system? Epinephrine, norepinephrine, adrenaline, right? So those increase heart rate. So what type of agents would we call those? Those are positive chronotropic agents. Absolutely. Acetylcholine. What do you guys think? Negative chronotropic agent, right? So here, positive chronotropic agents, negative chronotropic agents. Primarily, we're going to talk about the nervous system, but there can be effects from the endocrine and also some electrolytes and blood gases can influence the heart rate as well. So a few terms: persistent resting heart rate above, say, 100 beats per minute, tachycardia. So anytime you see the word tachy or prefix tachy, think of elevated faster, and then Brady is slowed down. So that's a resting heart rate below 60 beats. Yeah, go ahead.
Well, on that last slide where you had that image shown, you
Mm-hmm.
were talking about the
Yeah.
slope of
The membrane potential? Yep.
yeah, you're going to have two different individuals, one with heart rate that's higher and one that's slower.
Mm-hmm.
Basically, the action potential will almost
Action potentials are the same.
they're going to look the same, but the only difference is really
Yeah. Yeah, how quickly you get to that threshold. Exactly. Yep. Absolutely. Absolutely. And there can be issues if the person has problems with the channels that are part of the action potential, right? But that's going to be problematic whether they have an elevated or a decreased heart rate regardless, right? All right. So let me tell you a little bit of how this works. Okay, so sympathetic nervous system, right, releases epinephrine, norepinephrine, also known as adrenaline. So not surprisingly, these receptors that bind those molecules are called adrenergic receptors. And it also shouldn't be surprising to you guys that it's a G protein coupled receptor. All right, so it's a G protein coupled receptor, and it is going to generate the intracellular second messenger cyclic AMP. Okay, what was the first messenger? What bound to the receptor to activate it? Epinephrine, norepinephrine. That's the first messenger. Bound to the receptor, activated the G protein, right? And then we're going to make a cyclic AMP, make the second messenger cyclic AMP, right? In order to do that, we have to activate the enzyme adenylate cyclase. Remember that adenylate cyclase gets activated by that activated G protein. Now, if you remember, we talked about channels and gating of channels. And what are some ways that channels, the gating of channels, happens? So remember, gating's how channels are regulated to be open or closed. There are some ways that we can gate channels. Chemically? Yeah, absolutely. Chemically gated, ligand gated channels. And we had voltage gated channels. And then the last one was mechanical. Okay? Now it turns out there's some channels that are open by cyclic AMP binding to them, as well as other events. Okay? So here, what ends up happening is that there are cyclic AMP gated sodium ion channels. So like Tyler mentioned before, if we circle back, if we start opening up more sodium ion channels, right, sympathetic nervous system gets activated, binds to that beta adrenergic receptor, causes more cyclic AMP to be produced, which opens more sodium ion channels. What does that do to the slope? So I'm going to make it steeper or shallower. Steeper, we're going to get to threshold a lot quicker, right? If we're getting to threshold a lot quicker, what's that doing to the number of beats, say, in a minute? It goes up a lot. Okay? So this is how the sympathetic nervous system at the molecular level is able to exert positive chronotropic effects. Okay? It's through this beta adrenergic receptor. All right, so before I talk about the parasympathetic, I do have to tell you guys a little bit about some public service announcement about beta blockers. So beta blockers inhibit this beta adrenergic receptor. So, who might you want to prescribe beta blockers to, you think? So what kind of condition, if we have elevated heart rate, would you want to prescribe these beta blockers to? High blood pressure, right? Okay. So here, beta blockers, they're going to be an antagonist to this adrenergic receptor, right? This beta adrenergic receptor. right? Which means that if they're out and they run into a bear, right, is their heart rate going to go up as much? No. So it helps keep the heart rate from not going up as much when the sympathetic nervous system is activated. Now, in these cells, though, right, that blocking of the beta adrenergic receptor is sensed by these cells, and in order to try to compensate, it increases the amount of these beta adrenergic receptors on the cell surface. So we call this receptor upregulation. So if we start off with 100 and we block some of them, then the cell tries to compensate by putting, say, 200 on the cell surface. Okay? All right? And if we say that, only 50% of them are blocked with 100, okay, so 50 out of the 100 are blocked, okay, and then we upregulate to 200. Now we have more receptors that can be stimulated, right? So if we quickly go take that beta blocker away and someone gets in a situation that activates their sympathetic nervous system, now they have more receptors that can be activated, right? So rather than just 100, now they have 200 that can be activated. So what do you think is going to happen to the heart rate? Is it going to go up by a lot more? Yeah. Okay. So one of the problems with beta blockers is that the cells try to compensate by upregulating the receptors, and if you go off quickly from them, and then you activate the sympathetic nervous system, now you can really activate a lot of these receptors, right? Now remember, the sympathetic nervous system not only elevates heart rate, but it also increases heart contractility, right? So not only are you increasing heart rate in this individual dramatically, but you're increasing the contraction strength as well. And for those that are interested, so we talked about chronotropic agents, or agents that affect heart rate. Agents that affect contractility or contraction strength of the heart are called inotropic, I-N-O-tropic agents. So epinephrine, norepinephrine is both a chronotropic and an inotropic agent, right? So if someone is wanting to go off of beta blockers, how do they go off of beta blockers? Well, you can't go off cold turkey because of the problem I just told you about. So what you need to do is you need to taper off of beta blockers so that it gives cells the time to downregulate the receptors so that if the sympathetic nervous system gets stimulated, it's not overstimulating these cells. So that's my public service part of my talk. Okay? All right. So let's talk a little bit about parasympathetic, right? So there's two ways that parasympathetic decreases or interferes with increased heart rate. One is that activation of these cholinergic receptors. So cholinergic receptors are ones that bind acetylcholine, right? And not surprisingly, this is also a G protein coupled receptor. All right? Activation of this cholinergic receptor, right, is going to cause potassium ion channels to open. Right? Potassium ion channels open, what's that doing to the slope? It's making that slope shallower, right? Making it less likely to reach threshold. That's one of the major mechanisms. The other one is that it's going to interfere with the ability of the sympathetic nervous system to elevate heart rate. So the other thing it does is that it inhibits the enzyme that makes cyclic AMP, right? Because we said cyclic AMP is really important for the sympathetic nervous system to elevate heart rate. So one of the things that the parasympathetic does is it inhibits the enzyme adenylate cyclase from making cyclic AMP. And if we have less cyclic AMP, then it's less likely to open calcium and sodium ion channels, right? So there's two ways that the parasympathetic nervous system inhibits or decreases heart rate. So it's a negative chronotropic agent. So there's vagal tone, where there's tonic firing of the vagus nerve, like I said, and this keeps the heart rate held down to about 70 to 80 beats per minute, right? Because the normal SA node has an intrinsic firing rate, spontaneously fires at about 60 to 100. All right? Is that making sense to folks? How the system works, a parasympathetic versus sympathetic? All right, so there's a few other chronotropic agents out there, and you can kind of guess how they're going to work, right? So nicotine and metabolites, so coteine's a major metabolite of nicotine, that stimulates catecholamine secretion, all right? So catecholamines are going to be adrenaline, noradrenaline, right? So there, what's that going to do to the heart rate? So epinephrine, norepinephrine, is that coming from the sympathetic or the parasympathetic? Sympathetic. And so sympathetic activation is going to be what? Positive or negative? Positive, right? So here, nicotine and metabolites elevate heart rate. They're positive chronotropic agents. Thyroid hormone can upregulate adrenergic receptors, meaning that there's more of them. So kind of simulating that situation that I told you guys about. So if we have more adrenergic receptors, then there's more to be activated. What do you think that's going to do to the heart rate? So adrenergic, so adrenaline, epinephrine, norepinephrine. So we're going positive or negative. So hopefully people are thinking positive, because I don't hear you guys saying positive. Right? So definitely positive chronotropic effect. All right, caffeine and related compounds. What they do is they inhibit the breakdown of cyclic AMP. So remember, cyclic AMP promoted opening of sodium ion channels, right? And that caused a what? Positive or a negative effect? If you look back. So positive or negative? Positive, right? So here, anytime we're elevating cyclic AMP, we're generally having a positive chronotropic effect, right? And so here, remember, we activate a system. In order for that system to become activated again, we have to reset that system, right? So if we activate the sympathetic nervous system and make a bunch of cyclic AMP, we have to get rid of that cyclic AMP so that it can be activated again. And so not surprisingly, just like there's an enzyme to make cyclic AMP, there's an enzyme to get rid of cyclic AMP that's called PDEs, is short, phosphodiesterase. Okay? And so what caffeine or related compounds, they have many things that they target, inhibit. But one of the things they inhibit are these enzymes that break down cyclic AMP. So if you inhibit the breakdown of something, then it goes up, right? Now, the reason I have to tell you about this is that there is a PDE inhibitor that was being investigated by Pfizer a while back for treatment of blood pressure. And they were doing a study with some minors, M-I-N-E-R, not M-I-N-O-R, okay, minors. And the male minors, when the doctor came in to take a look at them, were all face down on their stomach. And turned out the reason why was because they were hiding something that was a little embarrassing. The other thing is they didn't want to give back any of the extra pills from this study. Right? And so they did a follow-up interview, and one of them said, well, I've been having more erections during the evening and the nighttime. And all the rest of them said, oh yeah, that's the same thing's happening to us. And so this is what is now known as Viagra. So it started off as a blood pressure medication in which some of the male participants didn't want to give back any of the extra pills. Right? It was a PDE inhibitor. Turns out there's a particular PDE in male erectile tissue that Viagra is really good at inhibiting, right? To maintain blood flow to that area to promote erection. All right. Yeah.
So, when you smoke for a while and you get them off, you get that done with beta blockers?
You could, if they're having, there's probably other issues that are involved too, though, It depends upon, what their blood pressure's like and what the other health history is, Certainly if they have an elevated heart rate, that's one way to go. Better is to, try to get off of smoking altogether, nicotine. But it's a really addictive substance, though. Really challenging. All right, so I just want to finish up here with talking about some electrolytes that are really important, chronotropic agents. So potassium has the greatest chronotropic impact. So anyone who's worked in the healthcare field and had to monitor patients, you know how important it is to check potassium levels. One of the reasons is because of the cardiovascular effects, right? So here, potassium ions, they can affect heart rate and also some other things in the body, but primarily in the heart is what we are concerned about. Now, calcium can affect heart rate, but remember, was calcium important for skeletal muscle contraction? Yeah, absolutely. It's just as important for cardiac muscle contraction. So calcium, it does affect heart rate, and it does have a chronotropic effect, but it has a much larger effect on contractility, so being inotropic. Okay? And so here, potassium and calcium are two major electrolytes that can have chronotropic effects. All right, so this will be a last slide, and then we'll break. A few differences between skeletal muscle and cardiac muscle. So here, skeletal muscle, here's our action potential, our membrane potential, and here's our tension. Notice how quickly we get tension, and then we have relief of that tension due to quick depolarization. We have a plateau in cardiac muscle. So it stays contracted a little bit longer, so you have a longer contraction in cardiac muscle. Why do you think you want a longer contraction? Why might that help a pump be more efficient? Yeah, so it's making sure it does a better job at pushing the fluid through its chambers and valves. Yeah, absolutely. The other thing is that with this long, what we call refractory period, then we're not going to get a quick contraction again, right? So the last thing you want to do is to have the atria contracting at the same time as the ventricles, right? So this long refractory period helps prevent, that happening so that we get contraction of one, then contraction of the other, right? The actual cardiac cycle. Okay. So just a few differences. Some of these cells are autorhythmic, or they spontaneously fire. Cardiac muscle, right? It doesn't need central or nervous system innervation. They can depolarize on their own. The other thing with cardiac muscle, those cardiomyocytes, they're stitched together tightly. And if one depolarizes, it causes the other ones to depolarize around it. So their cytoplasms are also connected. So they contract as a unit, right? So they contract as a unit. They have long absolute refractory period, and we talked about that, and that prevents this tympanic contractions. So they stay contracted and then they relax, right? And it prevents them from staying contracted for a prolonged amount of time, right? Tetanus. Okay? So just a few differences between skeletal and cardiac muscle. Okay, so why don't we take a break? And then after the break, we'll start connecting the cardiac conduction system with the ECG. Feeling about cardiac conduction, so some chronotropic agents, making sense? Yeah, all right, good. So what we're going to do is I'm just going to kind of give a little bit of an overview. Dr. Jack McKenzie is going to do a more in-depth look at ECGs in the lab for you guys, for those that haven't had lab yet. And so that's what we'll do next. And then, like I said, we'll do a brief blood vessel intro, and then I want to make sure to get to blood pressure. So we're going to skip over the capillary exchange, the forces involved with that, and we'll revisit those on Tuesday next week. All right? So that's kind of what we're going to conclude today's session with. All right, so the cardiac conduction system, it's an electrical signal. And if we have some electrodes, we can capture that electrical signal. And so the electrocardiogram, right, is a trace of that electrical signal from the cardiac conduction system, from the depolarization and repolarization events that go throughout the heart tissue. And remember, where does it start? What's the pacemaker of the heart? SA node. So it starts off with a little piece of tissue up in the up in the right atrium, right? That's the SA node. And it starts depolarization. But notice here that we don't pick up anything on the ECG trace, right? So why do you think that is? It's so small, right? So here, we just don't have enough electrical signal to pick up because not enough tissue is generating an electrical signal. It's not being depolarized, right? It's only a small piece of tissue, right? If we had, say, our electrodes were sitting right on the SA node, then maybe we'd pick it up, but we usually have electrodes that are on, say, the chest being the closest, or, we have it on our wrists and our feet, right? Or ankles, okay? So we start off with the SA node depolarizing, and then that depolarization is going to spread down towards the AV node and then towards the left atrium. So now we have enough tissue that's generating an electrical signal, that's depolarizing, that we start being able to pick that up. We start seeing a change on the ECG trace, right? So we start seeing a deflection here, right, of the depolarization of a lot of that atrial tissue, okay? And so here, when we've basically depolarized a lot of that atrial tissue, right, we've got depolarization of the atrial tissue. We pick that up as a deflection on the ECG trace. We call this the P wave, right? The P wave. Now, remember, electrical stimulation, and then generally, if there's no problem, what happens afterwards are parts of the cardiac cycle, the mechanical, physical movement, right, of the tissue. So here, that electrical depolarization of the atrial tissue is causing the atria to contract, and we call that atrial what? Systole or diastole? Systole, squeezing, right? So we get depolarization of the atria, and then the physical event of the actual squeezing, the systole, happens a little bit after that, right? Remember, we have to get the electrical signal first, and then the mechanical event happens slightly after it. Everybody following me on that? Okay? So just because I see depolarization here doesn't mean that it magically also has atrial systole right then and there. Happens slightly after. All right, so where's this electrical signal going to go to next? So where's it? AV node, right? It's going towards the AV node, right? And it's going to be passed from the AV node to the bundle of His. Now, once again, that's only a little bit of tissue, and so we don't pick that up on the ECG trace. And then once it travels through the interventricular septum, the bundle branches, right, we start getting a little bit of that electrical signal that we can start picking up. And so here we start getting enough tissue being depolarized, generating an electrical signal, that we start seeing a event here, okay? And then eventually that depolarization of tissue, right, spreads throughout the ventricular cardiomyocytes, right? And which part of the heart's bigger? The atria or the ventricles? Which one has more tissue? Ventricles by a long, long way, right? So here, when we get depolarization that goes on, it's a lot more tissue depolarizing. So what's that going to do to the, say, the size of the signal that we're able to capture? It's going to be a lot bigger, right? So the signal that we're going to be able to capture from the ventricles depolarizing is going to be much larger than the signal that we get from the atria depolarizing, because there's a lot more tissue being depolarized in the ventricles than the atria. There's just more tissue there, right? And so that's what's happening here. We get this huge ventricular depolarization event, okay? Now, we depolarize. In order to get back to resting membrane potential, what do we have to have happen? So we depolarize, then we have to repolarize, right? Okay? So here, there's a other wave on here. That's the T wave. That's the repolarization of the ventricles. Okay? So this is the depolarization of the ventricles. This is the repolarization of the ventricles. The P wave was the depolarization of the atria, right? Where's the repolarization of the atria? Where do you think that's at? Yeah, it's actually happening at the same time as the depolarization of the ventricles, right? Now, which one's a stronger signal? Which one has more tissue? Atria or the ventricles? Ventricles. So the ventricle depolarization masks the atrial repolarization signal because it's small compared to the atrial the ventricular depolarization, right? So you guys have a lot of this information in the lab, right? Because you guys are looking at the ECG, and Jack is going to tell you a lot more about the ECG and the leads and all the different deflections of the ECG trace. All right? Now, is it making sense how we're connecting the cardiac conduction system, the electrical propagation through the heart, with the ECG, the ability to record that electrical signal? Is that making sense to folks? So if you're confused, please say something. We'll talk more. We'll have time in lab. And the other thing you want to be able to do is connect what's happening with the cardiac conduction system with what's happening in the cardiac cycle. Right? The cardiac cycle is a physical movement of blood where we get atrial diastole, atrial systole, ventricular diastole, ventricular systole, and then it goes back and forth, right? So you want to be able to connect what's happening electrically with what's happening physically. Are we good? Yeah? No questions? Okay. So what we're going to do is I'll give a introduction into some blood vessels, talk a little bit about factors that aid in venous return, and then we're going to skip over to talking a little bit about blood pressure to help you guys out with the homework, all right, the discussion homework there. All right, so remember here that arteries are going to be carrying blood away from the heart, veins are taking blood towards the heart. We have capillaries, which are really small blood vessels that are going to be important for exchanging gases and nutrients. We have smaller versions of arteries that are called arterioles. Small versions of veins, when I talk about smaller, I'm talking about smaller in diameter, are called venules. Arterioles are also known as resistance blood vessels. So these arterioles, okay, also known as resistance blood vessels. And the reason is because through stimulation of the nervous system, they can change the diameter of the arterioles. And by changing the diameter, they can change resistance, what we call peripheral resistance. That's going to be really important when we talk about components or factors that influence blood pressure. Now, if you look at the walls of veins and arteries, right? So you can see here on this histology image, right? Lumen of a vein, lumen of an artery. What do you see about the blood vessel wall? Which one's thicker? Artery by a long shot, right? Why do you think it has a thicker wall? So why do you think it has a thicker wall? So why would you want to have a thicker wall on a vessel? More pressure, yeah, exactly. So the arterial system has much higher pressure than the venous system. Okay? So here, the veins, they don't need to have as thick of a wall. Right? Now, a few of the structures that make up the wall. So here we have a lumen, and if you remember back to histology, right? Where we have a lumen, the tissue that's directly making up the border of that lumen is going to be an epithelium of some sort, right? We have specialized epithelium here that we call the endothelium. And so these are endothelial cells that line blood vessels. Now remember, just like in histology, we had epithelium, and then we had basement membrane, and then underneath the basement membrane we had what? Connective tissue of some sort, right? So that generally holds true here with blood vessel walls. We have an additional tissue in here that is going to be smooth muscle in the wall. And a smooth muscle, when it contracts, it can cause that diameter to close, and when it relaxes, it can cause that diameter to open. That's going to be really important in controlling blood pressure. And so here, with the arteries, we have a little bit more smooth muscle than in the veins. The other thing is, with some of these arteries that have a lot of pressure being pushed on their walls, they stretch the walls. In order for those walls to go back to the normal size, there's elastic tissue in some of these walls that are close to having high blood pressure, right? Where is the highest blood pressure? Well, the closer you are to the main pump of the cardiovascular system, the higher the pressure, right? So what's a artery or an artery blood vessel that's close to the heart, taking blood away from the heart? Aorta, right? So the aorta has elastic tissue in it because every time the heart beats and squeezes blood through it, it bulges and stretches in order for it to return back to a normal size. Okay, it's got elastic tissue. Okay, so this is pretty much what I was just telling you, right? We have elastic arteries such as the aorta, and we have some muscular arteries, and then we have arterioles, and a high percentage of their wall is smooth muscle, so they can control peripheral resistance. Okay? And capillaries, which we won't talk much about today, we'll talk more about those, next week, are involved with gas exchange. And there's different types of capillaries, we won't go into that detail, but they're going to have ability to allow substances to move in and out of the blood tissue. Now, here you look at veins. Okay, you notice that the blood vessel walls aren't as thick because it's a low pressure system. Now there's three terms to talk about that group structures of the blood vessel wall. So they're called tunicas, right? So here, the most internal tunica is called tunica intima. The next tunica, which has a lot of the smooth muscle, is called tunica media. So I always remember that because of M in media and muscle. And then the tunica externa is where there's generally some structural connective tissue, right, to give some infrastructure to the blood vessel, right? For those that are going to want to investigate a lot more about atherosclerosis, right, sometimes what happens is this tunica intima grows, or the tunica media invades the tunica intima, and it grows so that there's a new intima. It's called a neointima, and it starts occluding that blood vessel, right? And so for those that start looking at atherosclerosis, there's some terms where these tunica terminologies are used. Okay. So this is pretty much what I was just telling you guys. Tunica externa is the most superficial. It's got reinforcing structures, reinforcing connective tissue, such as collagen. Oh, sorry, Sabrina, go ahead. That's arteriosclerosis. Atherosclerosis is a particular type of arteriosclerosis. And our atherosclerosis generally involves a fat deposition. It does, yeah. Mm-hmm. It's the mechanism by which it's doing it, though. It's doing it by fat deposition. And that just causes all sorts of problems. If you think about just smearing some fat on the interior surface of a blood vessel wall, think about all the problems that's going to cause, right? Those cells aren't going to be able to get by as well, and some of them would stick. The other thing is that fat has to be removed. Some of the cells start taking up the fat, and it causes problems for those cells because they're not specialized to store fat, right? They're not adipocytes. And so it causes all sorts of issues. And you can also start instigating some platelets, and then you have problems with accumulation of other structures involved in the clotting cascade. Right? Sorry, go ahead. Well, I think it's relative, So here, you take a look at an artery without having a lot of fat in it, and then, it's very pliable. And you start adding some fat to it, it becomes less pliable. And I think part of the problem is that it starts changing some of the dynamics of those cells, And then, there's also probably some other components that go on where it accumulates maybe some electrolytes, and you can get mineralization, that can go on, So there's a variety of things. And this could be problematic if you get, for instance, heart valves, right? So we're talking about blood vessels, but, a lot of other cardiovascular structures can be impacted, right, as well. All right. Okay, so tunica externa we talked about, tunica media, smooth muscle. Tunica intima is the innermost layer where we have a lot of the epithelial tissue, which is known as the endothelium, and then we have the central space where blood flows through. All right? So before we jump into talking a little bit about factors that influence blood pressure, and skip over the capillaries, I want to talk a little bit about venous return. Remember, it's the venous system is a low pressure system, and so it can be problems with trying to get blood back to the heart, right? Because it's a circuit, right? And so here, there's some mechanisms to help with that venous return. One is that there's a muscular pump. So here, a skeletal muscle that's sitting outside, surrounding veins, right? Can contract and help through a milking action, push blood through the venous system. So, for instance, jet fighter pilots that are pulling a lot of G's, right, where blood's pooling in the lower extremities. They tell them to tense the muscles in their legs. Why? So that it pushes that blood through the venous system back to their heart. Okay? So this is one of the major ones, is the muscular pump system to help with venous return. The other is the respiratory pump. So here, when our chest cavity expands and contracts when we breathe, right, those venous blood vessels there also kind of expand and contract, right? And so there's kind of a pumping action to help with move blood in the venous system back up towards the heart. So squeezing abdominal veins and thoracic veins, right, to try to move blood back towards the heart. Venoconstriction, so there's not as much constriction in the venous system as there is in the arterial system, but there's a little bit to help with trying to promote blood going back. And then gravity, so obviously gravity is not helping with blood return from the lower extremities back to the heart, but it could help with venous return from where? Above the heart, right? As long as we're thinking about, normal staying upright. Okay? Venous pressure gradient. So here, the vena cava, which is returning blood to the heart, has only 4 to 5 millimeters of mercury pressure. The venules, right, have 12 to 19 millimeters of mercury. So just like with concentration gradients, okay, where substances flow from high concentration to low concentration, right? Here, substances flow also from high pressure to low pressure. So here we're going to get high pressure to low pressure to help with return of blood in the venous system. And then last one is this cardiac suction, where basically every time the heart is pushing blood out of the heart, it's also kind of generating a pressure to pull blood into the heart, right? Okay. Now, the venous system also has some valves to help prevent backflow. So this is something that's a little bit different, and you might be able to see some of them for those. You can see some kind of bulges on some veins and those are a lot of times those are the valves, right? They help prevent backflow in the venous system. All right, so that's the factors that help in the venous return. Okay, so here's just quick review of looking at the difference between arteries and veins. So be sure to take a look at that. We talked a lot about these already. Okay, so veins have valves, arteries don't. Okay, so like I said, we're going to skip over this guy, and we'll come back to that. Oh, whoops. We're going to talk a little bit about blood pressure to help you guys out with the homework, discussion homework for next week. 2 major factors that influence blood pressure. Something called cardiac output, which we'll talk about in just a second, and peripheral resistance. So cardiac output is how much volume of blood that the heart is pushing out in a certain amount of time, in a minute, for instance. Okay? Peripheral resistance is going to be the resistance that the heart has to overcome to push that blood out. So peripheral resistance, we're talking about, say, some factors we'll talk about in just a second, okay, that are primarily peripheral arterial blood vessels. Okay? And so you can see here that we're going to be talking about the arterial system for peripheral resistance because bulk of that pressure is coming in the arterial system. All right, so blood pressure is a combination of cardiac output and peripheral resistance. All right, first let's talk about peripheral resistance, and then we'll talk about putting cardiac output into this blood pressure idea. Now, the factors that can influence peripheral resistance is the total length of whatever that tube is you're putting the fluid through. Okay? So the longer that tube is, the more resistance that fluid's going to encounter. So if you had a tube that you're trying to put water through that is only this long, it's not much resistance compared to, say, a tube that would be as long as this room, right? Okay, so length of the tube, okay, the vessel in this case, that the blood has to flow through is going to influence the amount of resistance that fluid encounters, in this case, blood. All right? The other one is viscosity of the blood. And so here, remember, what are some components of the blood? We got serum, plasma, so cells, right? Formed elements. So really we're talking about, plasma and formed elements. Okay? So say we have a lot of EPO. So we're making a lot of erythrocytes. What do you think is what influence is that going to have on viscosity? Start increasing the amount of red blood cells in this. It goes up a lot, right? And so you're increasing peripheral resistance. You're also increasing the work that the heart has to do, right? So viscosity can influence peripheral resistance. All right, last one, and this is the one that the body can control and it has a huge effect on peripheral resistance, is controlling the diameter of blood vessels, specifically arterioles. And this has a major impact. And the reason is that if you increase the diameter, double the radius of the blood vessel, okay, that decreases the resistance by 1/16. Okay? So it's 16 times less resistance. So having a small change in diameter or radius has a big impact on resistance. So another way to say this is that the radius, okay, the resistance is inversely proportional to the radius to the fourth power. This is pretty amazing. So this means that changes in the diameter of a blood vessel has major impacts on peripheral resistance. Okay? This is why changing the diameter of blood vessels by the sympathetic or the nervous system or by other factors is really important and a major mechanism by which the body can control blood pressure. Okay? All right. Okay, sorry, go ahead, Ashley. Yeah, but you can increase that firing or decrease the firing, and then you change the diameter, and therefore you change the radius or the resistance dramatically. Okay? All right, cardiac output. Like I said, it's volume per minute from the heart. And so here we've talked a little bit about stroke volume. I'll review that in just a second. That's how much gets ejected from the ventricle per beat. If we multiply that by how many beats we have in our minute, then we can figure out how many liters got ejected from the heart in a minute, right? If we know how many liters got, or how many milliliters got ejected per beat and know how many beats are in a minute, we can figure out how much total volume got ejected, right? Okay, so basically what we do is we just multiply those two together to get cardiac output Q. All right, so I'm going to do a little bit of board work here. All right, so blood pressure is going to be a combination of cardiac output and peripheral resistance, right? Cardiac output, we said, right? And who remembers that? Stroke volume, and then it's times heart rate, right? Okay. Now, how did we get to stroke volume? Anybody remember that one? So it was the amount of blood that we started with in the ventricle, right? So that is end diastolic volume. And then how much was left after systole, right? So that's end systolic volume, right? Okay. So let's figure out what certain things do to blood pressure. Let's say that we increase the amount of blood that we start with here, right? And everything else is going to remain the same. So we increase end diastolic volume. What is that going to do to stroke volume? It should go up, right? So that should go up. If that goes up, everything else is the same. What's that doing to cardiac output? Should go up, right? Which means what's happening to blood pressure? Should go up, right? Okay. All right, let's do another one. All right, so let's say we're going to decrease end systolic volume, and then we're going to increase heart rate. Okay? So here, if we decrease end systolic volume, what's that going to do to stroke volume? It's going to increase. Everybody see that? Right? So we're starting off with this amount, right? We're left with this much. Okay? So if you get confused on this, you can always put numbers in here. Right? So if we do, say, 8 and 6, right, to start with, now let's just put in something that's less than 6, right? So if we do 4, we get a bigger number. Everybody following me on that? Okay? So this means that our stroke volume would go up. What is that doing to our cardiac output? That's going to go up, and that's going to mean that we get increased blood pressure. Right? Everybody following me on that? Okay. All right. So let's do just one more. And let's say that we want to decrease blood pressure. All right? And then peripheral resistance we'll say is remaining the same. But that means that we want to decrease what? Cardiac output, right? So we want to decrease cardiac output. Okay? So if we want to decrease cardiac output, right? What could we do to stroke volume? Decrease it. Another way we could decrease cardiac output is decreasing heart rate. Let's say the heart rate stays the same, okay? And so we want to decrease stroke volume, okay? How could we decrease stroke volume here? We could decrease EDV. What's another way we could do it? Increase end systolic volume, right? Okay. Does that make sense to folks? All right. So you're going to want to take a look at this and get comfortable with it. All right. It's going to help you guys out with the homework and also for studying and knowing how all these systems interact with each other. Any questions on this before I let you guys out? Yeah. All right. Good. All right. So I'll open up the lab at noon for those that are in Thursday's lab. All right. For the rest of you, have a great weekend and be safe out there.